No. Good afternoon, everyone. I'm going to call the meeting to order. It's a couple minutes past 1. I apologize. We've got a busy agenda today, and we do have some folks who have said that they will be coming in late, so we will welcome them when they get here. But if we could please start with attendance, that would be great.
Senator Durant.
Present.
Delegate Hope. Delegate Tran.
Present.
Delegate Cohen. Delegate Scott.
Present.
Connor Cummings.
Here.
Beth Davis.
Present.
Parthenia Denora.
Present.
Ann Flippin.
Present.
Jamie Hanks.
Present.
Whitney King.
Present.
Giovanni Knight.
Present.
Ethan Long.
Present.
Mia Loria.
Present.
Brian McCann.
Present.
Tanya Milling.
Here.
Rose Neville.
Present.
Nelson Smith. Catherine Hayfield.
Here.
Karen Shelton.
Here.
James Williams. Lisa Coons. Cheryl Roberts. Terry Morgan.
Present.
Senator Pekarsky.
Present.
You have a quorum.
Thank you. All right, well, let's get started. We have a couple of presentations and several speakers. And if I could welcome Jason Perkins. We are very happy you are here and willing to come speak with us today. And this is a presentation on Medicare services and other resources that are available to persons who are living with autism spectrum disorders. Thank you.
Thank you for having me here today. I always open up by saying again, I'm Jason Perkins. I am the Program Manager for Developmental Disability Waiver Operations at DMAS. If you ever need to find me, I am not difficult to locate. I am the tall guy wearing bow ties and sweater vests. I am well known for this. I do not shy away from it. I call my general attire adult toddler. So if you ever need me, you do not have to look hard to locate me. I am going to be discussing with you all some services specifically targeted towards how we support youth with autism spectrum disorder. I'm going to spend the first half of my presentation giving you an overview of some of the support options in our developmental disability waivers, and then a little bit of insight into our applied behavior analysis programs through our behavioral health division. I have brought my handy-dandy pen and paper to take questions. I will endeavor to provide as much clarity as I can. On what I do not know, I will happily take back and get you the information that you need afterwards. And we are off to a good start. The technology is cooperating, so small victories. Very quickly, one of the things I always like to try to clarify when it comes to understanding our developmental disability or DD waivers is that there is actually no such thing as a DD waiver. We use that term colloquially to describe 3 separate waivers. Those being the Building Independence, or BI, the Family and Individual Supports, or FIS, and the Community Living Waiver, or CL. Now, for the purpose of our discussion today, I will be focusing on the FIS and CL waivers. Reason being, the Building Independence waiver, which is an amazing option, is targeted towards only adults who are living independently or are imminently ready to live independently. So we do not support youth in this particular waiver. So I will not be focusing on that waiver today. It's a great option, but it's not what we're here to discuss. The Family and Individual Supports Community Living Waiver have been present since our waiver redesign of 2016. They both offer an amazing package of supports and services to support people with all different labels of developmental disability, not just autism. I wish I could go over all of those with you today, but then you all would be here till sometime after the holidays. There are so many of them. So I have selected a couple of them to really go over in detail. The core of what we try to achieve with our developmental disability waivers is, and I think what is so relevant to this particular group, is the ultimate desire to support a person with where they're at, to provide them what they need to be successful with where they're at. And the ultimate goal of that is the least restrictive environment. We support people in a variety of 24/7 settings, inpatient, outpatient, but the ultimate goal is we want you to be living where you need to be the most successful in the most independent way as possible. The dream goal, your own home or at home with your family. And I actually give credit to our wonderful partner agency, the Department of Behavioral Health and Developmental Services, who takes the lead on a lot of this. They created this particular slide years ago to demonstrate how we try to take all of these things into account when we're determining how best to support someone successfully. So let me jump into actually one of my favorite services in the entire waiver program. It's one of the ones that is specifically relevant for our conversation today, and that is therapeutic consultation, with specific focus on behavior consultation. Now, first of all, what's the techie definition of therapeutic consult? I would like to go with the techie first. What this really means is it's a service that provides assessment, development of a consultation support plan, and teaching in specialty areas, including behavior support, to assist family members, caregivers, and other providers in supporting the person enrolled in the waiver. So what does that really mean? What it really means is this is a holistic approach to supporting someone with a developmental disability, in our case, autism spectrum disorder. This is not intended to be a primary version of direct therapy. Behavior consultation under the waiver can include some direct practice work. It's only allowed in the behavior consultation component. But the real goal of behavior consultation is to develop a plan based upon that person's unique needs to be successful, and providing education not to the person, but to all of us around the person. Let's be honest, in many cases, one of the bigger issues is not the person. The person is who they are. The problem is we don't understand what they need to be successful. Behavior consultation is designed to support a person who is providing care. You are with that person, you are mom, you are dad, you are brother, you are sister. You are a direct support professional in a group home setting. And you want that person to have the most success they can possibly have. A good therapeutic consultant through our waiver system can come in, review all the assessments, all the paperwork that's been done by a lot of great people already there, and develop a plan to give to you who's providing supports to that person on how to understand how they communicate, how they respond to their environment. What do you need to be self-aware of to ensure that person has success? So if I sound like I'm kind of geeking out a bit, I absolutely am, because this is such an amazing service option within our DD waivers. As I say here, it can include outlining interventions in your environment, adapting your environment, strategies to address issues and outcomes. Always remember, some of the biggest challenges, again, is not about the person, it's about how we interpret what the person is doing. On the flip side of that, therapeutic consultation is designed to do that holistic approach to give that person success in the least restrictive setting possible. But what do we do when the person is at a point where they need something more intensive? Maybe they need something more intensive than the least restrictive setting possible at that time. We do offer through our waiver program crisis services. Now, again, to give credit to our partner agency, the Department of Behavioral Health and Developmental Services, they operate something called the REACH program, which is designed to implement these crisis services to people in the community. Now, two of the primary pieces of what we offer in the waiver are what's called center-based and community-based. Now, center-based is exactly what it sounds like. It is us providing crisis to an adult or a youth in what we call a crisis therapeutic home. Now, this is not a standard group home. This is not a permanent group home. This is a short-term situation with 24/7 awake support to help address a person's imminent crisis needs, to allow them to get back to a place where they can get back to the least restrictive setting possible to be successful. DBHDS continues to grow our options for our center-based crisis supports. We operate 5 adult crisis therapeutic homes, and I believe, and if I am mistaken, I apologize, I think we now have 2 crisis therapeutic homes for youth with the goal of having more. So it is something we continue to grow and develop to help people be successful. The other one is community-based crisis supports. And again, it's kind of what it sounds like. This is designed to support persons who have crisis level need, but we're trying to do it in their own home. They are presenting a need that is more intensive than what we would be able to do like through therapeutic consult. But we are attempting to do so to help them maintain that safe environment of being in their home setting with their family. Any of us, I don't care what your label is, whether you have a label of developmental disability or a label of, like me, a nerd who wears bow ties. Any of us are going to feel anxious, stressed. We are going to feel not at our best if we're at a time of stress or crisis and they yank us out of our home. Always remember that. Put yourself in another person's shoes, and how would you feel if you were experiencing something that you are stressed out about? You're not able to communicate it the way you want to, and they say to you, we've got to take you out of your home where your bed is, where your stuff is, where your pillow is. Some of you may be able to relate to that. Sometimes, for me, I really miss, when I go home for the holidays, and if you cannot tell, I am not from Richmond, I am from Southwest Virginia. When I go home to see my mother for Christmas, I will take my pillow because I have to go stay for a week or she's going to come up here and I'll never get her to leave. So I will take my pillow with me because I will miss my pillow when I'm not at home. Try to remember those little things when we're trying to think how we best support a person experiencing these crises, and we're going to yank you out of here for a while. What would you miss and how would you feel? Any youth in our waivers are eligible for crisis services. They are also eligible for therapeutic consultative services. Now, let me go ahead and address one thing. We always work to strive to be better. DBHDS and DMS have partnered, and we have grown these services tremendously, but we still need to do more. We need more. We need more support for crisis. We need to continue to grow therapeutic consultation providers. DBHDS and DMS have done an amazing job of pulling people together. We have some amazing behavior analysts who work to provide therapeutic consultation. We have seen some amazing consultation plans and some amazing success stories come from this. Just so you can kind of see where we're at. On the DMAS website, let me apologize, there is a typo as I just noticed. That should say state fiscal year, SFY, not SFT. That looks like a wrestling maneuver from the WWF, so I apologize. That should say state fiscal year 2023. I sorted this data by youth, so this is 20 and under. Now, right now, please understand that we have approximately, at any given point, about 18,000 members enrolled into the DD waivers right now. That number will continue to grow as we continue to expand these waiver slots over the next 2 years. So I say that to recognize that when I say we have 645 individuals, members, receiving crisis and therapeutic supports, I'm pleased at that number, but recognize that number has room to grow. And as you can see, over the state fiscal year, we paid on an average cost per Medicaid recipient of about $5,400. Now, this does not include any other service but crisis and therapeutic consult, but I want you to kind of get an idea of how we are growing these services. And I would like for you to pay very close attention to the bar graph to the side. I'll explain why I want you to remember that bar graph in a moment. As you can see here, we see a progressive increase in utilization from 5 to 10, 11 to 13, 14 to 17, and 18 to 20. Please keep that in mind as we go on through the next part of our presentation, which is applied behavior analysis. And I'm going to come back to this at the close. On the behavioral health side, on the non-waiver side, I've spent the first half talking about what we do to support persons who are enrolled in the Developmental Disability Waiver Program. But what about people on the waiting list for the Developmental Disability Waivers Program? What about people who do not have a waiver at all? There are still a lot of great supports for them as well. One of the services that we offer through Medicaid that's available for anyone who is eligible for Medicaid as a youth is something called Applied Behavior Analysis, or ABA. Now, ABA means the practice of behavior analysis as established by Virginia Board of Medicine in the code. to the design, implementation, and evaluation of environmental modifications, using behavioral stimuli and consequences to produce socially significant improvement in human behavior, etc. That's the techie definition. What this is this is an amazing clinician who walks in, does what we call functional behavioral assessment, tries to understand how that person with the label of autism spectrum disorder communicates, how they're responding to environmental stressors and triggers that could cause them to have feelings of panic and crisis. This is direct therapy, direct observation, a lot of direct work, an amazing, amazing opportunity. In order to be eligible for applied behavior analysis through the standard Medicaid program, they must have a diagnosis, in our case, of autism spectrum disorder or another current psychiatric or provisional psychiatric diagnosis. We support a lot of persons in ABA who do not have an ASD diagnosis. It could be a complex ADHD diagnosis or other behavioral health diagnosis. They must meet at least 2 of the following criteria: nonverbal or limited functioning communication and pragmatic language, unintelligible or echolalic speech, and impairment receptive or expressive language. Very quickly, I always like to clarify, I hate the term nonverbal. It's a clinical term we use, but no one is truly nonverbal. You may just not use words to express yourself. I've yet to meet anyone who is truly nonverbal. If any of you have teenagers, they communicate quite well to you, I am sure, without using a single word. I see several of you nodding your head and you're thinking, I'm going to be nice to them at the holidays, but they're going to get it. But always remember, if you ever hear that term nonverbal, it is a relevant technical term. But you can say that Jason at DMS hates that word, and that's why. Because we all communicate in our own way. There also must be severe impairment in social interaction, social reasoning, social reciprocity, interpersonal relatedness, difficulty with sensory integration, disruptive or obsessive repetitive behavior. You can see all the requirements here. They have to meet at least 2 of these to be eligible to receive applied behavior analysis. The other key part of this is, in order to do this, there must be a family or caregiver available to participate in providing the service. There must be a partner in this. Because for any of us to get better, to get the support we need someone there partnering with us to get there. You need an accountability buddy. We all need that. ABA can include assessments, the treatment, group adaptive treatment, family adaptive behavior treatment guidance. And the reason I want you to see this is because this is what, in the therapeutic consultation world of DD waiver, they will review these things as part of their process to develop that plan to give to the caregiver to support the person with autism. So in a lot of ways, this is the primary direct work with the person with the label of autism spectrum disorder. On the DD waiver side, therapeutic consult can be what we're doing with all this information to support all of us supporting the person with autism spectrum disorder. Now, this is why I want to nerd out on my data for a moment. This is the utilization data for state fiscal year 2023 for applied behavior analysis. About 7,400 individuals received this through Medicaid, average expense about $25,000. But I want you to look at the bar graph of the age breakdown. It's the inverse of what you saw with the developmental disability waiver therapeutic consultation. We see a lot higher numbers in the lower age ranges, gradually reducing as we get to the higher age ranges. I take that as a positive indicator to say we recognize at these younger age range, we're trying to get to the person as early as we can. The earlier, the better, to give you the support you need to be successful. Then as you get older and you start engaging with your environment more and more people need to understand how you need to be supported, we need to be having that therapeutic consult step in to help us. So when I look at this, I go, my data, of course I love data. I was very excited by this because this makes logical sense. We target with ABA younger, and we intervene with therapeutic consult later. I'm going to go back just for a moment. Oh, I'm doing golden on time. Wonderful. I wanted to tell you about a few other services that I do not have time to go into in detail, but just so you know, for the waiver, in addition to offering behavioral supports, in addition to also being, and just so if you're in waiver, you still have Medicaid, so you're also eligible for applied behavior analysis if you're in waiver. The waiver also offers some amazing options such as community engagement and community coaching. This is what we call a day program. Community engagement, community coaching is designed to support a person to be fully integrated into their community in small group settings of either 1-to-1 or 1-to-3. And it's just what it is. It's designed to take a person to go to the movies, to go shopping, to do the things we take for granted every day that we don't see why it's such a big deal. Oh, of course, I'm going to go buy Food Line, or I'm going to go buy Publix and buy my groceries. Think about how complicated that is, and we take it for granted. When you go into a supermarket, when you go into a movie theater, and we walk in and we pay for the ticket, and we buy our popcorn, we pick up our groceries, and we price compare and price shop and make those effective judgments, that may seem like, oh, well, yeah, that can be very complicated. Community engagement, community coaching is designed to provide supports and plans to help you get through those daily tasks and be successful doing it. The other one I want to briefly talk on is something called in-home support services. This is my second favorite behind therapeutic consult. This is supports we provide to a person, youth or adult, in their home, either their independent home or their family home. And it's designed to support life skill development, independent living skills. It can also be used in conjunction with behavior support management to help you be successful. And I could go on with 50 other bullets, but I won't do that to you. But these are some other ones to keep in mind as you think about the waiver system in general. So I've tried to leave a couple of minutes at the end for any questions that I can try to answer. Again, if I do not have your answer, I will take it back and get it for you and send it through the appropriate channels. So are there any questions that I can answer for you all?
Mr. Perkins, thank you for your presentation. We appreciate it. And I will say, just for me personally, something you said that was so incredibly poignant, and I think just really what we need to focus on a lot of times in the policies is that it's not the person, it's the people around them and their interpretation of behavior, and knowing how to have the tools to do that. I think that is just so incredibly important in this conversation. I do have a question, but I'm going to open it up first to our members. My screen is not working for some reason, so if you don't mind, please go ahead.
Mr. Jenkins, thank you so much. A quick question. The data you gave on 645 members had used therapeutic consult and crisis services. Therapeutic consult is very different from crisis services. Do you have the specific number of who used the crisis services versus the therapeutic consult?
I did not pull that for this presentation, but I can absolutely pull that for you.
Great. And just two quick points, Madam Chair, if I may. One, Mr. Jenkins did a great job of making the waiver system very clearly discussed it, but we can't kid ourselves. It is a frustrating and difficult process to navigate. There are 7 levels, 4 tiers, 3 waivers. Families don't know what they're getting in. I think that this a group would have time well spent if we spoke about the SIS, the scale intensity support, which is part of that 7 levels, 4 tiers. I constantly hear from families on how degrading, embarrassing, and terrible that process is for families to go through, and I think we can take a look at that. The second thing I would note in the JLARC study of 2009 that we're supposed to monitor and implement, and in the November 2010 DBHDS came out with some recommendations to educate people on waivers. And I still, to this day, constantly see individuals who have been through specialized education graduating at 22 and have no idea what the waiver is. And there is one potential easy solution to this. The vast majority of the people who are receiving services on the waiver have gone through specialized education. I think it would be good for us to possibly talk about at IEP meetings, simply just notifying the families and having a checkbox for the school jurisdictions to say they notified the families, they gave them the information, and do it at every triennial. That way we won't get 22-year-olds wondering what's a BI waiver, a FIS, and the community living. Thanks.
Thank you for that. I will say, just on a very personal note, I 110% agree with you. Having gone through the process, having had to get the information on my own because it was never brought up, and we had already gone through the process when the school system finally brought it up, and that is too late. So I think there is space, especially when we're talking about our priorities and about things to look at for next year. I think this is definitely something that would behoove this group of people to understand, and look at and discuss if there are ways to make it better, because it is extremely frustrating, which is what you brought up. Thank you. Any other questions?
If I may offer, what I can do is I pull this data for you. We actually on the DMAS website have developed some wonderful data dashboards that are public facing. I will provide the links to those dashboards for you all to have access to. And you can actually sort all of the waiver services by utilization. So I'll also provide those web links when we provide you the data.
Does that data get as granular as for those who are using the home supports? How successful it was for those services for that individual to stay in the home versus actually having to go somewhere else after
It is,
receiving them?
on the DMAS side, it's only the utilization data, so it'd only be the billable data.
Okay,
Good question, thank you.
Thank you. Go ahead.
Just a quick question. Why does the data only go to age 20?
For the ABA,
Well, for the ABA, but also the therapeutic consult.
oh, thank you for that clarification. Actually, the therapeutic consult does not have an age requirement. It is available for anyone in the waiver for either adult or youth. So thank you for that. On the waiver side for therapeutic consult. For the applied behavior analysis, the cutoff is actually tied to something called EPSDT funding, which is early periodic screening, diagnosis, and treatment, which is a funding stream that we get. Each state receives a pot of money for EPSDT funding. It's designated for children under the age of 21. So ABA is connected to that.
And so is ABA available for adults or folks over children in Virginia? No.
Therapeutic consultation is,
Okay.
but the ABA is not.
Got it. And what do you think is there's only, 700 out of 18,000? What do you think is the biggest barrier to folks getting therapeutic consult?
That is a very good question, and I will have to defer till I can do some more research for you on that, because I do not always have I would have to get a good view of what the individual needs are, the person's coming into the waiver. The need for therapeutic consult would be tied to actually having a behavioral support need. So I, without doing more research, could not look at you and say that that number is underrepresented, but I will happily look into that for you. It's a great question.
Hello, everybody. So I can also speak to that. I'm a positive behavior support facilitator, and I provide behavior consultation.
Very cool.
So it is loosely based around the support coordinators ask that question when they do their monthly visits regarding if there are any behaviors in place and things of that nature. And they have since updated it to wonderfully now automatically make that referral for behavior consultation. As someone that provides the service, the barrier is the caregivers. They may not want to participate in it because it is them that have to do the work. It's not direct therapy, as he stated. So that's what I find to be a huge barrier.
If I could respond to that, one of the in my day job, I run a program that provides services, and one of the services we provide is therapeutic consult. One of the issues we have is the rates, frankly, to provide that service, because all of those things you mentioned that are a part of that, evaluating the plans, the individual, being able to synthesize that, working with families, working with group home providers, that's a very difficult job. And one of the things that I know our group is experiencing is that it's very challenging with the rates that currently exist to be able to sustain that. So we end up fundraising in an effort to be able to support that effort for some of our adults that need that service. So one of the challenges that certainly personally I see is that we just aren't paying enough to get that type of support to folks that really have those needs.
Thank you.
Any more questions? Thank you. I had a question about the day programs. I was recently at a I visited a group home in one of my communities, and one of the issues that they have seen is that the availability after COVID is a very big obstacle for them. I've heard it from parents as well. Can you speak to that and what the current status is, what the hurdles are, and what are we doing to kind of work on it?
COVID, of course, changed everything. I mean, that's a cop-out answer, but COVID changed everything. What I can say is we have seen a progressive increase in the utilization after we've come out of COVID. I don't know if we're back at pre-COVID utilization levels or not, but I will research that for you. But I do know that we are constantly working, and again, we work with our partners at DBHDS to continue to get the word out, to help try to attract new providers into the system. We recognize that can be, and I'm glad that is a big process to become a Virginia Medicaid enrolled provider. We recognize that. And we're constantly trying to simplify, make it more approachable, so when a provider says, hey, I want to do this, we want to be able to say, we want you to do it, and let us help you get through the door. Because I recognize that can be a big step to get the coordination with your Office of Licensing at the Department of Behavioral Health, to coordinate with the Medicaid enrollment provider system at DMAS. So we are constantly trying to improve communication. I can honestly say I'm engaged in a weekly conversation with DBHDS and how we can streamline that process better. So, but I will go back and do utilization review for you and see what I can find out regarding pre- and post-COVID utilization of day programs.
That'd be great. Very helpful. Thank you.
Madam Chair, the 1 to 7 ratio day programs are pretty sustainable. It's the need that are the 1 to 2, 2 to 3 that going back to Ethan's. I don't want to harp on rates, but it's about funding for that population.
Thank you. One more question. And I'm glad you like data, because I'd love to get the data on this too, because this is something that I've also heard is of a concern to folks, is about the crisis supports that we have in the communities, where they are, who has access to them. I would love to get data around that, because I think that continues to be a big need and issue. And I'm hearing it from hospitals as well in my community. So anything you can share with us would be extremely helpful.
I will happily bug my partners in crime at the Department of Behavioral Health. They also love data.
Perfect.
So I will happily do that for you.
Thank you. Thank you. Any last chance for any questions for Mr. Perkins?
I will talk all day long if you let me, so be forewarned.
Well, okay. Thank you. We really appreciate you being here and doing this. I know it's a busy time right now, but it's very helpful. So thank you.
Happy holidays to all of you.
Happy holidays.
Happy holiday.
I think we have welcomed 2 legislators since we started, Delegate Cohen, Delegate Hope. We're happy that you are with us. We just finished our first presentation, and we are going into our second presentation, which centers around professional trainings on autism. And I think we are going to start with Ms. Ann Flippen, our very own member from the Autism Society of Central Virginia.
Good afternoon, Madam Chair and fellow members of the Council. It is such a pleasure to have the opportunity to share information with you all about several of the programs that we offer with the Autism Society of Central Virginia. I have provided significantly more information in the slides than I will cover, but consider it a resource and feel free to reach out anytime with questions or anything you want to learn more about. For those of you all who aren't that familiar with the Autism Society of Central Virginia, we are based in the Richmond area. We were founded over 40 years ago by a group of parents that came together to support their loved ones with autism, their children, and each other, and create this community of understanding and support. And since then, we have really grown. We tried to be a source of support, resources, navigation, connector for the community. As we know, the autism community has grown. We've tried to grow alongside the community and fill gaps and lean in as much as we can. We serve the entire spectrum and the entire age span and through a variety of programs. So this just outlines the types of programs we host. We have about 800 active members in our community, constantly growing. And we try to lean in and support as much as we can. So today I'm really just going to focus on our community trainings and some of the more recent focuses that we've had as an organization. I think due to the demand and the trying to serve the broader community and create this true community of understanding, make it more accommodating for our families as they often feel really isolated and alone in their journeys. So these are the different types of trainings that we offer. We've started with an Autism 101, which we've been doing for several years now. And due to the number of requests from different types of businesses and organizations and professions, we've really tried to expand this really in the last 2 to 3 years. And we always try to collaborate with partners in establishing these subject matter experts, bringing in the lived experience, whether it's self-advocates, it's parents, it's professionals in the different fields that we're covering, depending on the type of training. For example, Giovanni here is one of our trainers, and she really focuses on the neurodiversity in the workplace training because she can speak firsthand about her experience as a self-advocate in the corporate environment. And when we do our first responder programs, we typically co-present with a law enforcement officer or someone in the field. One of the programs I'll just mention briefly is our most robust training program is called Autism Friendly Communities. And this is where we partner with organizations. You can see a few of them listed here where it's a really intensive program where we work with them for several months to build tools, resources for them to utilize, as well as doing training for their staff, whether it be by department or, for a lot of these museums, it's the front desk staff, it's the volunteers that are interacting with their clients. One example in particular that I'm going to highlight is KidMed Urgent Care. They have 4 locations in Richmond and Fredericksburg. And they actually approached us about 2.5 years ago as they saw this being a real gap. They were seeing more and more patients with autism, and they did not feel equipped enough to be able to give them the level of care that they really wanted to. They really saw that as a gap. So they were really a pilot for this program, and we worked with them. We surveyed their staff to assess what they saw as gaps, customized trainings for them. We surveyed our parents and what does their experience look like when they go to this urgent care setting? What are they experiencing? What do they wish they were experiencing? And then we created a lot of resources, whether it was calming items, sensory kits, shot blockers when they were getting poked with needles. And we also developed resources like sensory guides, what to expect when you visit. We also put a new waiting feature in place where you get in line virtually, so you're not sitting in the waiting room for an hour. That's actually helped all of their clients. But that has really led us to, more and more medical providers are finding out about what we did with KidMed, and they're reaching out to us wanting the same kind of supports. So we've expanded this program and really created what we're calling sensory-friendly practices, where we're going in and we're able to give them a lot of these tools and supports. Most recently, we've had more early childhood educators and preschools and daycares reaching out, wanting support. We're also hearing more and more from families that their children are being kicked out of daycare and they're not able to support them enough, or there's behavioral issues that they don't feel equipped to support them well enough. So we were fortunate to recently get a grant from the Robbins Foundation to pilot this program, where we'll be going into preschools, giving them a lot of the similar types of training and support that we're giving the practices I just shared about, but also giving them equipment and supplies and more tools to help them. And then the last program that I will share about is our first responder training program. We were really fortunate to get a 3-year grant from the DOJ through their Covenant Avante program, which is focused on reducing injury and death of missing individuals with developmental disabilities. And we've really focused in on law enforcement officer training. So we have a presentation and tools that we give law enforcement officers, and it's been very, very well received by different departments. We really focus on the Richmond area specifically, but we're really, really pleased by the buy-in and the interest in law enforcement officers, especially to get our training. I did provide some survey report results just from a couple of our most recent trainings, just to show the unfortunate lack of knowledge and skill around supporting individuals with autism before, and then how much they learn through working with us. And we try to keep all of our training very interactive. We talk through scenarios, real world examples, and make it as helpful for them as we can. And this is an example of a communication board that we developed that we encourage officers to keep with them in their cars, and also have provided other emergency response individuals to utilize as well. Also through this same grant, we provide sensory safety seminars and fairs. So we have 2 different models for this. One that is supporting families, young children, and those with higher support needs. And it's a fair environment. Really, the goal is for the first responders to have opportunities to interact with the community and interact with each other. And so this first format is really this fair atmosphere, face painting and games and fun, and they've been going over really well. We always provide tools and resources to both the first responders and the families, whether it's, we have window clings that you can put on your car. We have little cards that you can put in your glove compartment or your wallet, and also telling them about Project Lifesaver and other types of programs that might be helpful to them. The second type of seminar that we host is for teens and adults, and this is really interactive where we practice scenarios. So whether we do actual traffic stops where they're in a car and they practice getting pulled over, we do pedestrian stops, talking through scenarios of calling 911, when to call 911, when not to call 911, what to do if you witness a crime. We also do a virtual reality session for caregivers so they can see what it's like from the officer's perspective. And actually, that was a really eye-opening activity last year when we did that. Lastly, I'll just share that we helped champion a bill last year with Senator Bagby and Delegate Willett, and that was for DCJS to establish minimum training standards for law enforcement officers on communicating with individuals with autism. And since then, we're really excited that the bill passed, and since then they've developed a task force that has involved stakeholders and individuals with autism, parents, and law enforcement officers, and put together training standards. And we met several months ago, and since then it's gone through several rounds of approvals, still several to go, but so far they haven't had any edits, and we're feeling really positive about where that's going. And they do have until June of 2027 to implement it and roll it out. So that is all my content. I believe that Rose is joining us virtually to share more.
Hi, can you all hear me?
Do you want to switch?
Thank you, Rose. Yes, we can hear you.
Great. Thank you, Anne. So while my slides come, my name is Rose Neville. I'm a clinical psychologist and part of the leadership team of the Autism Initiative at UVA called STAR. Our mission is to help improve the lives of people with autism and their families through research, education, and outreach. And Anne kindly invited me to share a little bit about our training initiatives because we partner closely with the Autism Society and are doing a lot of collaborative or parallel work in other parts of Virginia. Next slide, please. The first training program I wanted to highlight closely follows what Anne just described. We at UVA have a Department of Defense funded research grant that is aiming to disseminate autism training to emergency responders across Virginia. We are validating an evidence-based curriculum titled the Autism Response Protocol that we've developed over the last 2 years using community input and to really address a lot of the issues that community members have raised around their concerns of using 911 during crisis and the general theme that they don't call 911 when they need to because they're concerned about the lack of knowledge and autism appropriate treatment that they will receive. So this grant is aimed to establish 2 evidence-based training packages, one that is entirely online and one that's hybrid, so that once the project is complete, we can disseminate these programs across communities in Virginia, regardless of their access to a live autism trainer in their region. We will be disseminating this to over 224 first responders in interdisciplinary groups, so not just law enforcement, but also training, fire rescue, and EMTs, because all of these emergency professions need to know how to effectively support people with autism during crisis. And we've learned that discrepancy in response approaches ends up ultimately exacerbating crisis for autistic people and their families rather than helping. Our curriculum was updated and it is in alignment with the training standards that DCJS has just updated following the House Bill 1248 mandate, or 46 mandate. So, and we are working with criminal justice academies across Virginia now to share this content so that once that mandate goes into effect, they will have access to a curriculum. And we're also working closely with the Autism Society to ensure that our content we teach aligns really well with their fantastic efforts under the DOJ grant. Next slide, please. We're also doing a lot of work to try to increase capacity among primary care providers across the state, particularly in medically underserved regions. So the Academy of Pediatrics recommends that all children be screened for autism at 18 and 24 months. However, this is very inconsistently happening because many providers lack the knowledge of autism and available screening tools. So we have been using a free case-based learning model called ECHO, which allows us to reach into communities through video teleconferencing to teach primary care providers on effective evidence-based training methods. And so far, we have reached 52 pediatric providers across the state and to train them on screening, and 32 to train them in more advanced diagnostic practices. We're also teaching them how to treat co-occurring conditions and access community resources and referrals such as EI. And Dr. Beth Ellen Davis, who is on the council, is one of the co-leaders of this project, so she could also share more about this. Next slide, please. Our program, the Autism Initiative at UVA, is housed within the School of Education. So we are doing a lot of work to also increase teachers' capacity to support autistic students in the classrooms. One project titled Including Preschoolers with Autism was developed in collaboration with Charlottesville City Public Schools and Old Dominion University to establish a curriculum on how we can teach preschool teachers how to support students with autism in early childhood settings, particularly in rural, underserved parts of Virginia. And what we find is that traditional lecture-based style of teaching, which is less effective for adult learners, is also equally less effective for teachers. And what we're doing with this program instead is using a combination of group-based coaching, classroom observation, and feedback so we can continuously shape early education providers' capacity to teach and support young learners with autism in those academic as well as important life skills. And what this project is really tackling is the huge need for autism awareness in early childhood settings. Currently, 1 in 6 children with autism in the preschool age are being kicked out or expelled from preschool settings because they cannot handle their behavior or manage their educational developmental needs. Next slide, please. We also are working in collaboration with Virginia Tech to provide coaching to general education teachers within rural Virginia using that ECHO model that I mentioned a few slides ago. This is an 8-week network that we have piloted thus far, teaching teachers in gen ed settings how to identify autism and support behavior, communication, and social skills, and we will be continuing to implement this across the state. This is really critical because as we see the rate of students with autism growing, currently 1 in 36 children are being diagnosed with autism, we're seeing that is a growing number of students who are being served in the general education setting, no longer just in special education. So we really need to increase general education teachers' capacity to support autistic students. Next slide, please. And then finally, we are one of the 2 sites in Virginia next to VCU who offers a leadership education in neurodevelopmental disabilities or LEND program. This is part of a nationwide network funded by the Health Research and Services Administration, aimed to improve the health and well-being of individuals with autism and developmental disabilities by providing interdisciplinary trainings to graduates from a broad range of health disciplines through a year-long program. You can see the disciplines on the screen. They range from family advocacy, self-advocacy, to medicine, speech path, OT, and psychology. And trainees in this year-long program receive coaching and education on core information related to autism and neurodevelopmental disorders, advocacy, how to disseminate knowledge and resources into communities. We have so far trained over 2,000 professionals across disciplines. So this is a very exciting program to be a part of in order to help increase the capacity to support autistic people across the state. Next slide, please. And that was all. I wanted to keep it short, and thank you again to Anne for letting me also share about our programs at UVA, but I would be happy to discuss any of these projects more offline or at a future meeting. Thank you.
Thank you, Rose and Ann. We really appreciate it, and all the work that is being done to support individuals living with autism. And I believe we have one of our own members who has some comments for us. Connor Cummings, go ahead.
I am so excited about trainees for police and safety officers, as well as first responders. In addition to the training that Ann and Rose are speaking of that, I will be participating in. The ARC of Virginia is working on a national grant from the ARC headquarters in Virginia. This grant is for in-person training in Norfolk, Virginia to include Fairfax, Arlington, Alexandria, Loudoun, and Prince William. I, along with my mom, be on the panel participating in the training. The grant is from the Bureau of Justice Assistance for 6 months, and then it will go online to be accessible and free for anyone. The start date will be in early 2025. We will also be working with Lucy Bino from the ARC of Northern Virginia, the head of a crisis center, and a couple of retired police officers. My mom and I have seen on Facebook other disability athletes, affiliates, who will have training with grants as well. We are trying to remember who they are or find them so that we can all connect and be a strong force throughout the state of Virginia. We have so many great disability affiliates throughout Virginia, and I am so honored to be working with a few of them. Together, we are strong. Together, we can and will make a difference. Together, We will reach so many individuals and families shining a light and hope for each and every one of them. This is what we can all do together, the best of all of us.
Connor, thank you for sharing that with us. How exciting about the grant. And thank you for your work that you'll be participating on. Do you promise to come back and give us updates as you are participating on the panels and working through this?
I do.
That's excellent. Thank you. Very exciting. Do we have any questions for, go ahead, Delegate Hope?
Thank you, Madam Chair. There's really a lot of great educational programming going on, and Connor gave a good example of that. And we heard some presentations from Ms. Neville and Ms. Flippin about it. I had a question about the first responder training, and I'm wondering if there's any way to create some efficiencies within that training. I know there needs to be a distinction between CIT training and the autism training response protocol curriculum that you have. But is there any way to combine that? Because there's a pretty robust effort to have that not just in the academy training, but ongoing training for law enforcement as they need to get certified. Is there any way to make sure that that could be part of the curriculum, or does it need to be separated with different opportunities? I just worry that we're not spreading it and being as efficient as quick as possible to make sure that people have that background. For anyone who may know the answer to that question.
Who would like to tackle that for the delegate?
I have a comment.
Okay, go ahead, Ms. Neville.
Sorry if there's ambient noise. I'm in an airport at the moment. But the CIT training does cover autism, but it only has a very small portion of the 40 hours that they are able to dedicate to this topic. And we find that they need much more intensive education on this in order to really learn what they need to support them.
Thank you. That is a helpful answer. Ms. Flippin, did you want to add to that?
I would echo what Dr. Neville shared. We get requests from CIT to do training specifically on autism because they're sharing they're not getting enough.
Thank you. Go ahead, Ms. Cohen, Delegate Cohen, sorry.
Either's just fine. Thank you so much for this work. Truly, I think that we are getting there. It feels, inch by inch, I think sometimes. And to your point, as we see more and more folks diagnosed, I think that we're always just feel behind in this work. But I really appreciate, and I think the areas you've highlighted are so important. A couple just that we're seeing kind of in our older adolescents / young adults. I think we all talk a lot about that 18 to 22, when you kind of fall off a cliff from your high school support. And so the two areas that I'd be interested in learning more about maybe next year as we go forward are definitely emergency department staff. I think that continues. We've had that conversation when it comes to TDOs, when it comes to placement, and we just seem to be seeing it in our hospital systems over and over again, that I think the interaction is so poor that leads to such poor outcomes. And if people just had some competence in it and comfort level, that we might be in a different world. So I would love to see more information, whatever you can get to us on that, how we can be helpful. And the other is higher ed. I think that our disability services folks are outstanding in our public colleges and universities. But what I don't see is then our professors, staff, housing staff, food service staff having any real tangible understanding of how this impacts how you navigate the world once you're on a college campus. So it isn't just about extra time. It isn't, sort of the accommodations piece that we think of in education. But I'm just seeing with my own kiddo as they navigate school, how often they are having to try to train professors, even though they have established, accommodations. So I wondered about any ideas that you all might have for us, probably for a session beyond this, but of how to do a better piece of helping our folks in higher ed get where they probably want to be.
Does anybody want to address that or have any comments?
And I'll share that I agree. I think for us, it's a capacity issue. We're getting so many requests for trainings, so it's being able to keep up with that. But with I think the university setting is such a great example because there's so many different layers and interactions and different types of accommodations. And there's a lot of simple things you can put in place that really go a long way. It's just how do we get more capacity to be able to get it out there more that's the main roadblock, I would say. But the interest is certainly there, and we know the need is there.
Thank you.
I was just going to add, I think, a lot of colleges and universities have that floor of the ADA and the Rehab Act, and then it's a little bit of the wild, wild west. It kind of depends on who the people are and what their motivations are, and there's some fabulous programs that do everything really, really well. And I have a son who's 18 that I'm looking at a lot of these colleges and their autism support because I'm experiencing it myself. And then but I think it's voluntary. And so a set of standards that go beyond what you have to do legally, I think would be a really helpful tool so that people have something kind of to base these practices on. And it's not just, there's a champion that has a connection that makes the university carry out those practices. Instead, it's something that is a little bit more standardized. So yeah, I echo what you're saying.
Well, I'm hearing, go ahead.
Just one quick comment. A couple areas of concern. One, in 2009, JLARC did this study and spent a lot of time saying this is what we need to do. And in 2010, DBHDS came out with a 20-page plan of what they were supposed to do, and nothing got done. So we've talked about this for 14 years, and nothing's gotten done. So I hope maybe we'll get something done. But what is that something? So you got Autism Society, who's doing great stuff. You've got UVA, who's doing great stuff. You've got Northern Virginia, who's doing great stuff. The issue and the expertise is there. It's the coordination. And I think that's where the state can come in. What is everybody doing, to Delegate Hope's point, to disseminate this? I mean, we at FASN, we train the FBI. So everybody's doing something, but there's no coordination. So, are there inefficiencies with Autism Society doing something that the Autism Society in Northern Virginia is doing? So that's going to be a common theme, I think, with autism and on this is the coordination of it. The expertise is there. So I would just encourage us to think, is there a solution with the state helping coordinate what everybody is doing to get it out there?
Well, I was going to say this is a great transition into the next part of our agenda because I do agree with you. I think this will probably be the bulk and a lot about what we discuss going forward. And for anyone who doesn't know or has not seen, those recommendations and that report were posted online, and I think taking the time to read through them would be very helpful because, obviously this is our last meeting for December and we're in session, but when we come back, I think we're going to be in a different position to try to lay out a more robust schedule of priorities as we are moving forward, and something we will vote on, and I think that will be our very first agenda item as we come back together in the next few months. And I think I'm going to now pass the baton to my vice chair, who has
vice chair. I'm not vice chair. Am I vice chair?
Yes, you are. Come on. Somebody needs a break.
Oh, I'm vice chair.
If you can speak.
Yes, I can. I thought Laura Jane would be a better vice chair, but anyway, I'm here for it. Thank you, Madam Chair, for that. No wonder why I'm sitting next to you. All right, now it all makes sense. I think that there's good recognition. One of the things I wanted to mention, what the chair talked about is having resources and the ability to get some of these ideas that we've talked about here and put them into action. And I think the Behavioral Health Commission has long sort of seen itself as the entity that has had autism under its sort of jurisdiction, so to speak. But there is just so much going on in the mental health space, and there's just the good sense of the chair Deeds and others have figured out that they just don't have the bandwidth to give autism the attention that it needs and deserves. And that's why we have this council that's set up. So with that, given that the Behavioral Health Commission had felt like it was in their purview, and now that we have the council set up, they wanted to take some decisive action to transfer that authority, jurisdiction authority of autism, to the Autism Advisory Council. And to that end, I think you really need to, these are ongoing issues that need attention. And the Behavioral Health Commission put forth a proposal, a recommendation, and it passed unanimously to make the Autism Advisory Council a permanent commission. And so there are two aspects that you would need. That would be legislation that would be required to change the statute, the one that you authored, Madam Chair, to create the council. As you know, it expires in 2027 is when we call it sunsets, I think 27 or 28. But this would circumvent that and make it a permanent commission in the code. And then the second piece of that was to give it budget language that would give it two FTEs, 2 staff, because the issues that we're dealing with are going to take multi-year effort, and we're certainly going to need the commitment of staff and the support of this council here to put some of these things into action items. So I do think that it's, on the one hand, a little bit awkward for a commission to tell other commissions to make themselves permanent, and I said so, but I think I do understand now, because it was felt that that was in their purview, they had to take action to transfer that over. I do think the action for this council at the moment should be to also adopt that same legislation and support both aspects, the making this a permanent council and one that has 2 devoted staff, 2 FTEs to it. And so it would require also a budget amendment. And that's my motion.
Thank you, Delegate. Quick question, is there a second, or can we just pause? Would you be willing to pause for a second on that so that we can ask our staff here to talk a little bit about what does it mean to go from being a council to a commission, and is that okay with you? Okay, so yeah,
Madam Chair.
Go ahead,
Thank
Senator.
you, Madam Chair. And I believe we did see there was budget language this morning in the governor's budget for, am I not mistaken? I think, is anyone confirm that, or do we know?
Senator, somebody looked quickly for me and did not see that, but
Okay.
that doesn't mean, if we do a little bit of a deeper dive, that would be great if it's in there. If not, we're
Forgive me if I'm
obviously-
mistaken
No,
on
that's
that.
okay.
So maybe
That's
it was
okay.
just.
Yeah.
That'd make our job easier.
Yeah, that would make our jobs easier.
Good, okay.
I love it. Do you want to go ahead, Julie, talk to?
Thank you, Madam Chair. So for the purposes of this council, I think the main differences of significance depend on exactly what avenue is taken to do this. So there's 2 options. Legislation could be brought that would turn this essentially into an independently staffed legislative commission, which would do all the things that were just discussed in terms of you have a subject matter expert staff, essentially, that are dedicated to the specific purpose of the council or commission is what it would become. The primary change that would be most significant is that for independently staffed legislative commissions, there are required to be more legislative members than non-legislative citizen members. So that would result in a significant reduction in the amount of non-legislative citizen members that could be appointed to the commission if it were sort of dissolved and reestablished that way. The other option would be for it to be established as an advisory commission in the executive branch, in which case there would be independent staff along those same lines. It would have a greater degree of permanence. It would be permitted to have this essentially the same composition of membership. There would be some small differences, as it wouldn't be under the legislative branch anymore. It would be under the executive branch of the state government. And so there are some finer points there, but that's the main differences of significance.
Thank you. I appreciate that. I thought it was important for us to know that and kind of share, if you have anything to share, thoughts on that before we bring that motion to the table. As the delegate said, this is the recommendation of behavioral health. And obviously, we understand the pros of this. You have a professional staff. They are able to do the research. They work with us on getting a lot of the information and the questions that come up. And I think the work that you are able to do is really bolstered and helped with folks that are subject matter experts and have the time to delve into it and bring that information back to the commission. And the policy that you see that is recommended that comes out of these commissions is oftentimes easier progressed through the legislature. Not always, but oftentimes. So with that, I will open it up to thoughts, comments. Go ahead.
Yes, Madam Chair, just one comment that I'd like to provide on if we were to create this as a commission under the executive branch. There is current law that requires a sunset clause to be on that initial legislation. I think it's a 3-year sunset clause, and it would have to be revisited. So this could not be like a permanent, long-standing thing. It would have to be incremental. And so that's something that I've come across with drafting language for executive boards and commissions over the years.
Yeah, that's a good point. Thank you. And also, I think the work that you see that comes out of an advisory to the executive branch versus if it was under the legislature's umbrella is also different. So I think that's important to note as well. We would not have, authority over that. Go ahead.
Yeah, Tanya, with the ARC, we support any focus that we can have on all of these issues. You mentioned the Behavioral Health Commission and how autism often fell there, but there's also the Disability Commission, and we always want to remember, that autism is a developmental disability, and so we want to focus on autism. So if this is another way that we can raise all boats, then great. I just think we want to be deliberate and remember that commission is there as well.
Yeah, thank you. I agree. I think in many ways we are unique. I mean, more children are being diagnosed with autism daily, and those children are obviously, as you all know, becoming adults, and the services are oftentimes disjointed. The education to parents in the community is disjointed, not because there is not goodwill and a lot of good work doing, but because of what was brought up, there is no coordination of these. And I think that is somewhere where this possible commission could do a lot of work to, make the Commonwealth the best place to live as a person with an autism spectrum disorder. Any questions here, comments on this? Okay. If not, I will say, if we do vote to recommend, as Behavioral Health did commission, of course, we always have public comment. So, and that is a very important part of these meetings. So voices will always be heard. And I don't think we can ever do our work. And I know legislators take that very seriously when we are trying to put forth good policy. So I just wanted to mention that. And with that, I think I'm going to go back to the delegate to offer us his paused motion.
I would move that we support making the Autism Advisory Council into a permanent commission, and we also support the supporting budget language. I think it's $400,000 starting in fiscal year 26 to support making this a permanent commission.
Thank you. Is there a second?
Is that a legislative commission or
legislative?
Yeah. Is there a second? Second. Excellent. It's been moved and it's been seconded to offer making this legislation from a council to a commission and a budgetary amendment. All those in favor of doing so, please raise your hands. Okay. All those against? All those abstaining? That motion passes. So hopefully we will have some good news coming out of this legislative session. And we are going to be able to come together and do some great work. There's definitely a lot of need, as everybody has been said, and a lot of good things happening. So with that, we are not done, though. Bear with me a few more minutes. We had a couple of other things on the agenda. The Blue Envelope program that Massachusetts is doing was brought up by the senator last time. I think everyone has some information on that. I just wanted to make sure everybody got a chance to look at that. Personally, I think this is extremely interesting, and I think this could be something that we talk about perhaps going into next year, because there are stakeholders that our police, of course, that I think we need to have conversations with. Do you want to talk a little bit about that, Senator Durant?
Certainly. Thank you, Madam Chair. I think this kind of ties in pretty well with some of the initiatives that we have brought over, Delegate Hope and I brought over from the Behavioral Health Commission. So it could be an important piece of it. It certainly doesn't necessarily have to be mirrored, but I would love to have those stakeholders come in, and the members of the commission. I think we had some offline conversations about there was some familiarity, which I thought was a good sign, but maybe there's some tweaks, improvements that we bring to the Commonwealth that make it, hopefully work well for our purposes, and based on best practices that we've seen so far, maybe some needed adjustments. So I'm pretty excited about moving forward with this.
Yeah, I agree. Me too. And I think after session, I am going to reach out and happy to work with you to get some input and see how something like this could work in the Commonwealth.
I welcome that. It was my chief of staff who, who's really great with, I think who's excited to help kind of tie in with it. So we'd be delighted to work with you on that one.
Thank you. Anna, go ahead.
Yes, Madam Chair. I like the idea, and I would be curious to see how this would work alongside of current code 46.2-600.1, which allows for identification of special needs on the driver's license. I had a similar piece of legislation that was actually kind of redoing what was already in the code, so we got to revisit it and see if there's anything that needs to be changed in the current code. And so I would like to be part of that conversation, and maybe we can make this a one-stop shop type thing, so any additions that need to be added to that list of disabilities that are identified in the code, we can also add this in there and maybe make it a little bit more inclusive to some of the other things.
Absolutely, I agree, and that was actually some of the questions that I had, so definitely want to work together because I need to build my own knowledge base on that. Don't want to be duplicitous, want to be efficient in what we're doing, so thank you. I'm going to turn it over to Delegate Cohen because Delegate Tran does have some legislation that she wanted to share with the council, and thank you. And I believe was going to ask us to perhaps have a public vote of support for this legislation that I actually am also carrying in the Senate. Thank you, you too. So go ahead, Delegate.
I'm so much taller than her that it'll be hard to. Delegate Tran had sadly to go to another commission meeting, so we only got to steal her for a little bit of her time, but she did leave information on two bills that she's hopeful that we might consider supporting, as Senator Pekarsky said. The first is an alternative communication bill that she has carried multiple times that would require teachers and staff in public K through 12 schools to provide direct support to students who utilize AAC devices to be trained on those devices prior to the start of the school year. what we have continued to see in, I would imagine, the vast majority of our school systems is that those folks are not on extended contracts, and so they are given training as soon as school starts, which means we leave an awful lot of our kiddos without the ability to communicate. And I think that definitely goes against what we all hope and dream of for our kids. So helps them on not just the isolation piece and some of those social pieces, but also learning loss. We have seen multiple instances where people are not fully trained on these devices until October or November, so months when kids are not. So that's the first bill. Do you want me to go ahead and say the second one, or turn that over to you?
Delegate, yeah, let's just take a moment are there any questions on that? This is a pretty straightforward, I see a hand. Do you want to go ahead? You go ahead.
Is there any definition around what the training would look like a time requirement for that? Or is it specific to what the AAC device would be, so student specific?
Yeah, I think that it would be student specific. I know that has been, an issue that we even had Senator Bukowski and I coming from Fairfax School Board of how many different devices that we're talking about. So because we recognize that the vast majority of principals are before they're leaving school for the year figuring out who belongs to whom, we would make sure that they'd be able to be trained on that student's individual device.
Any other questions? Yeah, I'll just say this is so vitally important. I mean, we've seen this playing out in real time where these kids are sitting in these classrooms for months on end, unable to communicate with the adults around them and others. And that, I mean, there is no excuse. I mean, communication is just basic. So I am fully supportive of this because and that's why I'm going to carry the Senate co-patron to this, because it is just critically important. So if there is a motion for this, I will entertain it.
I make a motion that the committee would support this AAC device bill.
Is there a second? Seconded. Are there any comments around that? Okay, let's take a vote. All those in favor of supporting these pieces of legislation, raise your hands. Okay, all those against? All those abstaining? That's unanimous. Thank you. Delegate, you want to talk about the second one?
Yes, Madam Chair. The second is another bill that Delegate Tran has carried multiple times, which is, again, an accessible technology bill. What it would require is state and local governments and higher education institutions and also public K through 12 to ensure that the technology they use to deliver government services in classrooms and et cetera is accessible across all disabilities. So something that we have been working on, I think, as a Commonwealth, and certainly has been a priority, I think, for several local governments to ensure that anytime that they're putting up, any sort of, be it a PowerPoint presentation or information on their website, that it's formatted in a way that anyone who's using any sort of accessibility device would be able to see all of the content instead of just bits and pieces. So I know that Delegate Tran's worked on this. I know at least in the past she's had a budget amendment. She didn't put that here in my cheat sheet. So, and I think, one of the ideas is that there was a lot of money in the budget last year for all of our different agencies to start updating their technology. And so the hope would be that as that happens, that this is included as well. I think hopefully put a smaller price tag on it.
Thank you, Delegate. Any questions about that? Comments? Okay, I'll entertain a motion then.
I'd like to make a motion that the committee support Delegate Tran's accessible technology bill.
Is there a second?
Second.
Okay, any comments? Dialogue? Go ahead.
Kathy Mayfield from DARS. I have a question whether this goes beyond the ADA in terms of the requirements?
Maybe, good question. I don't know if we could have Julia comment on that. I don't want to put you on the spot, but if not, then we can pause.
Thank you, Madam Chair. So I don't know off the top of my head. I will have to look into it. It may go beyond in the sense of heightened specificity, but not in purpose or objective, if that makes sense. And until I look further into it, that is all I can say for sure now.
Thank you, Ms. Bergamini. I see the delegate.
I know that a piece of this is ensuring that any technology that is purchased, so it also has a procurement angle that as school systems in particular, but also state and local governments, as they are purchasing any kind of technology, be it testing software, that all of that would be. I will piggyback and say that we are putting in a bill that would make a website a public accommodation. So I think maybe that speeds back to the ADA piece. I don't know that I can speak as eloquently as I'd like to about it before the committee, so I'm not asking for the committee's support on that one just yet. But so we're hoping that these kind of go hand in hand, and that did come from the Disability Services Commission, the public accommodation piece of website. I don't know if that helps answer.
Go ahead.
And I believe that
Well, this is not my bill, delegate. This is not the one I am working on. That's okay. I will say, I don't know. I would assume that Delegate Tran probably has done a lot of work on this, considering she's carried it before. But because she is not here to answer, questions, I'm not sure we could give you a more succinct answer than that.
one other thought,
Go ahead.
would there be additional costs that Department of Ed would have as a result of this?
For sure. My guess would be yes. Do you know?
Yes.
Yeah. Yes. So it would have to have a budget amendment as well. So, other questions, or go ahead, Delegate.
My apologies. I also have two bills that I'm hopeful that we might be able to support that I think have a greater impact on our community here that we're here to talk about. I have a bill that sorry. Did we?
Delegate, that's okay. We have a motion and it's been seconded, and we had some questions that I don't think we were able to fully answer necessarily, but we do have to deal with the motion. So you want to go ahead and restate your motion, and we'll take that vote and move on to your next bills.
Yes, understanding that certainly there are some larger questions, and I think anybody could probably go back into the legislative session from 2023 and see the last version of this bill, the Accessible Technology Bill. I know that Delegate Tran has been working this for the last 2 years, so I am certain that she would feel very comfortable with helping answer some of your questions. So my motion would be that our council support Delegate Tran's Accessible Technology Bill.
Okay, and that was seconded. So all those in favor of supporting this bill, please raise your hands. Okay. It is, in concept. Yes, in concept. Thank you. All those against, abstaining. Okay, and that passes as well. And now your bills, Delegate, you want to present to us. Are you looking for a vote of support or, okay, go ahead.
We have two bills, and my apologies that we don't quite have our drafts yet. I know everybody in DLS is killing themselves, and then we steal Julia for this meeting. So, but the first of my bills is a bill that piggybacks on last year. I had an emergency evacuation bill that talked about the ability of students to exit the building in the same manner as their mobile peers. This bill actually goes a step further, which is to talk about any emergency procedures and safety plans that they would be attached as an addendum to students' IEPs or 504s, so that instead of living with the building, that they would live with the student. And in particular, I know in our area, we are fortunate to have a huge military population who leaves and then comes back to our school system, but often in a different school. And we want to make sure that the student knows what their plan is, that their parents know what their plan is, and the parents would need to sign this addendum as well. So just making sure that this is an overall part and parcel, speaking to how students know how to be safe and know what the plan is that they have. So that's our first bill that I would ask this committee to consider supporting.
Are there any questions around this bill? And there is going to be the Senate. Go ahead.
So of course, this will be individualized. So would this be the schools writing these safety plans?
Go ahead, Delegate.
Thank you, Madam Chair. This would be just in the similar vein of how we craft our IEPs now. So schools, but in concert with our families as well. And of course, as kids get older, in concert with our students as well.
Go ahead.
What prompted the need for this legislation?
We've had several incidences where parents did not understand that their children who were on the second floor of school buildings, that in a fire emergency, for example, that they'd be put into a FISA room and left until first responders could get to them. We had at our home school a situation with a child where alarms went off and there had been a clear miscommunication about what the plan was for that child in the event of an emergency. And we've had several students who have been left in places where there's some confusion. In particular, I think of lockdowns or stay in place where students are in the bathroom and they just are not certain where they're supposed to be because they weren't in that classroom. So this in particular helps, I think, our disability community, anybody who's making use of an IEP or 504 who might need that extra help in having a very defined sense of what is going to happen in each scenario.
Any other questions? Go ahead.
You may have mentioned this, so I apologize, but is this a consideration for each 504 and IEP team? And if it's not required, then the plan is not created? Or is a plan created for each student? I think the concept's really good. We've recently done striker chair training with trainers that are going out to train each building to make sure that where we have 2 floors that is current training, and I've talked about that process, but just want to make sure that it's more of a consideration.
Yeah.
Delegate.
What we're currently envisioning it is that it would be an offering when families sat down to work on their IEPs or 504s at the beginning of the year and at the end of the year.
So not a requirement that each student has a plan, but that is considered.
Yes.
Thank you.
Go ahead.
Sorry, but
Go ahead.
and maybe if we had the bill, I understand they're drafting, but like to ask us to weigh in on it without having to see it. So like for us right now, the DOE requires our private special ed day to have emergency plans for tornadoes, lockdowns, going in without power, fire. And are you going to add each of those specific criteria to the IEP in each instance? Or like how is that going to play out practically?
Sure. I think, because these are so individual, our thought process is that if you have a student who's on a second floor, I imagine that the conversation about about evacuation generally would need to be included. If you have a student like mine who struggled particularly during a tornado drill, I might be able to have that conversation as a parent that we're good in understanding the safety plan of X, Y, and Z, but we specifically want to make sure that they know this part, or a lockdown drill. So again, we foresee it as a conversation that families and caregivers are involved in, to be able to say, these are the things where my student is particularly struggling. And so we'd like that included. So completely hear what you're saying and appreciate it. Again, this is a work in progress, so I do understand if this just needs to be more of a conversation. I sure appreciate getting these questions now and not in front of committee. So this is the perfect thing that we'd be really happy to continue the conversation and work through with you.
Yeah, I like it in principle. Again, it's like, and what happens if the child moves from the first floor to the third floor or to the second floor, and then what happens when the drill goes, and those sorts of things. It just, the practicalities of it is what would be, but in theory, would support it.
No, sure. This is exactly why we have these conversations, so happy to connect with you.
Thank you, Delegate. Other questions around this? My question is, have you had these conversations with DOE and what is that feedback?
We had the opportunity to meet with Superintendent Coons yesterday, and again, while I want to make sure I'm not committing to anyone without actual legislation and bill numbers, but in theory, the idea that it be an addendum, not require the IEP process to be completely opened up again, all things that Senator Prakarsky and I certainly have been on both sides of, so that it be an addendum and be having these conversations. But to your point, having a safety plan about each of these, I guess my gentle pushback would be that those plans exist, even if it's en masse at a school, and that you do probably uniquely tailor them to individual students because they all have different needs. So I think trying to figure out how we bridge that divide of not putting this onerous amount of paperwork, but make sure that in these scenarios that our kids are in a safe spot. So happy to continue working on that.
A formal motion on that, or you just wanted to share on this? And we should keep workshopping. Okay, keep workshopping it. And your second one?
My second one involves our public colleges and universities. We had the opportunity to work with Chev last year on a study bill talking about IEPs and their role as proof of a disability in our public colleges and universities. The study is definitely something that is worth reading, but the one real place of agreement was that IEPs that were valid in the last 3 years should be accepted as proof of disability, not to determine accommodations, as I know those are completely very, very different, but if they're used in the last 3 years. We've been working with colleges and universities to finesse that a little more to make sure that those give some guidance that transition IEP documents should include some of the ADA languages that colleges are really bound to. We also will be putting study language in that asks Chev to take a look, even though I know we've had JLARC reports, I know there's good language, but to your point, I think we really need some more work around standardizing transition IEPs and making sure that colleges and universities and our students have what they need. So we're going to put language around that in the bill as well, is to make sure that a study would happen that could, work with colleges and with schools and make sure that they're getting the information that they need. So this is a carryover from last year's bill, but last year it was turned into a study.
Questions, comments? Thank you. Do you want to offer a request on this one? That one I would love to. Okay, please go ahead. Yeah, please go ahead.
So when you talk about standardizing transition IEPs, are you talking about just the transition year from high school to college, not transition in the sense of 14 and up? It's a transition IEP.
Yes, transition in the sense of hopefully is happening in a perfect world in your senior year, just from high school to whatever is beyond. The study would be on the transition piece. The proof of a disability would be codified then that your IEP would be sufficient proof of disability.
What's the pushback? What's the argument against?
I think the argument against has tended to be that we know that IEPs that live in high school can sometimes contain a lot of things that is not super helpful to higher ed institutions. I think there was fear that we would try to mandate some sort of accommodations because that is such a different world. The bill explicitly says that we are not in any way mandating accommodations, that those are to be worked out together. And so I think, and I think a generalized, we've seen this across the university system, that some colleges and universities, the process they feel like is working very well for them, and they would like to not have it dictated. And some who are happy to have this because it's such a piece of what they already do. So it's just been very interesting. Institution by institution has been pretty different.
Thank you. You want to offer the motion? On my own bill? Yeah, on your own bill. Why not? Nobody better.
Sure. I'd like to make a motion to ask the council to support our bill on public colleges and universities accepting IEPs as proof of disability.
Is there a second? Okay. Comments? Any more comments? Okay. All those in favor of supporting this bill, raise your hands. All those against? All those abstaining? All right. You have this council's support. Good luck. But we still have public comment, and then we will be adjourning. So if anyone is here or online to offer comments, please come forward. Okay, I see one person. Please state your name. Go ahead.
Good afternoon. Thank you, Madam Chair. I'm not going to miss an opportunity to speak to you guys because we've all worked so hard for you to be here. I want to thank everyone again for being here and for participating in this. I would like to express support. Teresa Champion with the Virginia Autism Project, and also a public input member for the Behavioral Health Commission. Like to support the idea of the commission to be established for this group. It's so important for you all to have staff, and staff that will do the work, the hard work that you all are going to be preparing. We've tried to use the channels that are already in existence. We went to the Behavioral Health Commission, and they were very clear, and finally, as Delegate Hope said, defined their purpose, which is to work on psychiatric and mental health issues. And they're very narrowly defining that. But our population gets shoved into those processes and policies that they establish. So we had to have a voice in the room for that, because when they're proposing these things for the mental health community, we have to stand up and say, you know, that's not going to work for the autism community, and here's why. So while behavioral health is narrowly defined, not narrow because there's so much to be done there, has defined their focus, the Disability Commission does exist, but that is more, it seems to be more of an overarching policy group. So you see their agendas are about transportation, workforce, housing, things like that, that affect the whole disability community. And so just as the mental health community has unique and specialized needs, the autism community does too. And so we went and tried, we had a work group, Senate Bill 176, House Bill 888, and they came back with a big fat goose egg for this community. So we have to have people like you who are experts with a staff who can make recommendations. You saw the statistics in Mr. Perkins' presentation. ABA utilization goes down, crisis services go up. So there's a reason why that's occurring, and we need focus on that, and wonderful things are being done by Ann and Rose, just fabulous things. And the Northern Virginia is doing wonderful things. Thank you so much, Connor, for serving as you do. So first responder training is very important. But all the ERs need to be trained, as was mentioned, all of the people that are involved when someone is in crisis. So medical care for adults is crucial. Take that kid med idea into the adult doctor scenario, because they need to be informed also. And in closing, I would ask you to please support and consider legislation that you did as a legislature support last year, was passed last year, that we're calling the affirmative defense to protect people with ID, DD, and mental health. This is not the bill that it was originally introduced last year or the year before. This is a very narrow, small fix. It's an off-ramp for people with autism, ID, DD, mental health issues in the criminal justice system. And hopefully we'll get it passed and the governor won't veto it. So thank you so much.
Thank you. I see one more person coming up. State your name, please.
Brian Kelmar. I'm the president and co-founder of Decriminalized Developmental Disabilities and a father of an autistic son. I echo the comments that Teresa just made. They're very critical that what you guys are doing, and we haven't had a lot of luck in the past couple of years, so we're looking forward to you guys being an actual official committee. So thank you for that. A couple of comments. Brian's comment of coordinating all these efforts. There are a huge amount of great efforts going on, and there isn't a coordination. I think one of the things to consider, I don't know what you want to call it, is an autism czar in DBHDS, like other states have. They have a specific area and group that handles autism specifically. So I hope you consider that. The bill that Teresa mentioned and the other one that is being introduced by Delegate Watts is the diversion program early up in the criminal justice system. I think we've talked about it here, but it's also been talked to the Behavioral Health Commission. I hope you all support that. Thank you.
Thank you. Seeing no other public comment, are there any comments from the council? Go ahead.
Really quick, I wanted to recommend for 2025 if we could ask the Department of Behavioral Health, DBHDS, to come and do a presentation from the crisis system. We're continually hearing about crisis. People may not know we're part of Link Policy Academy, and I think contacting April Dovell to have them.
Yeah, thank you. I think that's a great recommendation. So we'll look at it as we come back, and very important and needed right now. Thank you all. Thank you for being here. Thank you for your work and for caring. And thank you to our presenters. And I hope you have great holidays. And with that, we are adjourned at 2:47. Wow.
The Senate of Virginia, Richmond, Virginia.